Welcome everybody to the World Parkinson's Day seminar. I'm just going to start with an acknowledgement of country. So we acknowledge the Palawa Pakana of Lutruwita, the traditional owners of the land on which we live and work. We pay respects to elders past and present as the strong knowledge holders and sharers, and we honour their strong culture and knowledges as vital to the self-determination, well-being and resilience of their communities. And we stand for a future that profoundly respects and acknowledges Aboriginal perspectives, culture, language and history. So we're really fortunate today to have this joint seminar. It's a seminar that is joint between Menzies, Wicking, Parkinson's Tasmania, and we've invited in the community as well. And so if you're someone living with Parkinson's or know someone living with Parkinson's, we particularly welcome you here in person or online today. So Parkinson's is made by a clinical diagnosis of slowness as well as one of stiffness, tremor and postural instability. But there are also many non-motor symptoms, as you can see under the iceberg there, that often occur many years before diagnosis. And we've got Sam Bramich today who's going to talk a little bit about some of those non-motor signs, particularly sleep. The average age of diagnosis is 60 to 65 years with more men than women, and there are over 200,000 Australians living with Parkinson's. As you can see, the average age is 60, so some people are under that, and we'll have Celeste talking today about Parkinson's and employment. There's no cure or disease-modifying treatments. And I think it's also important to recognise atypical Parkinson's disorders, which there are many, and also need a lot of research and investigation, but because of their smaller prevalence, they're often not, researched as much as Parkinson's disease itself. So we launched the Tasmanian Parkinson's Project back in February 2024. That was Professor Jane Alty and myself as the co-leads, and we've now got over 4,000 people. We're aiming for 5,000. So as you can see, there's some brochures or flyers on your seats, so please join up. We're looking for people living with Parkinson's and also not living with Parkinson's, so please ask your friends and family to sign up as well. We don't just do research, we run a series of webinars. We've run over 20 webinars ranging from a whole lot of different topics, from mime to Parkinson's to exercise, sleep, diet, whatever you could think of. We've also done some trips around Tasmania to Ulverston and to Launceston to talk about the Tasmanian Parkinson's Project as well. And there's a QR code if you don't have a flyer. Some of the research that we're doing, some of the research led by Jane, is looking at differentiating prodromal Parkinson's from Parkinson's itself using different tests, particularly TAS tests, which is a key tapping test, as well as listening to someone's voice, and also doing some other tests as well that you can see there to differentiate between Parkinson's and prodromal Parkinson's. We have a whole range of other projects, including Parkinson's in employment, the prevalence and health economics of Parkinson's. We've got collaborations with external researchers, one clinical trial that will be starting out looking at falls prevention, and you can see that the list goes on there, as well as being funded by a number of different organisations like NHMRC, the Michael J. Fox Foundation, the Royal Hobart Hospital Research Foundation and the MRFF. We've also, as I think you know, launched the MOOC. That's been incredibly successful with over 30,000 enrolments from 160 countries now. And just recently, the first National Parkinson's Action Plan was launched in Canberra, and really proud that Tasmania had a really important role in the development of that action plan. You can see in that photo there's Tracy, who was a founding member, as well as Dr. Harley Stanton in the middle, who really drove the need for the action plan. Claire Meyers here from Parkinson's Tasmania as well. Really exciting to see that launched. So we've got three really exciting speakers today talking about a whole range of different topics. We've got Sam Bramich, who's a PhD candidate and sleep scientist at the Wicking. She'll be talking about sleep and Parkinson's and some of the prodromal signs. We've got Claire Meyers from Parkinson's Tasmania, who's the chair and president. And then finally, Celest Holden, who's also a PhD candidate here at Menzies. So I'm going to pass over first to Sam to talk about sleep.
All right, thanks so much, Michelle. I'm Sam. I'm a sleep scientist. I've worked in the area of sleep for about 14 years now, and I'm also a final year PhD candidate with the Wicking Centre. And my research is really focused on some of the earliest features of Parkinson's, or those prodromal stages that we don't know enough about and need to understand a bit more about why people develop these symptoms and go on to actually develop Parkinson's and other related neurodegenerative diseases. So a bit of an overview of what I'll talk about today. I'll do a bit of a brief rundown on sleep because we all do it, but we often don't know much about what it is or why we do it. So I'll start off with that, and then I'll go into isolated REM sleep behaviour disorder, some of the challenges that we have with detecting it in the community, and what we're doing about that with our research at Wicking. So I guess first of all, sleep, it's a different state of consciousness. So sometimes we think that it's just where our brain turns off and nothing really happens. But as you can see in this little graph figure that I've got there, it really is a continuum. So we have a few different sleep stages where we've got REM sleep, deep sleep, and light sleep. And they come with different levels of awareness and consciousness. So depending on how deep our sleep is, depends on, our brain waves, and that's how we kind of measure those different stages. But we know that we don't completely turn off during sleep. There's actually a lot going on. But as we've got here, it's a different state of consciousness, and it does involve reduced responsiveness depending on the level of sleep, relative immobility. We don't tend to move a lot during sleep, and those distinct brain activity patterns are what really dictate what... Not close enough. Okay. The brain activity patterns is how we tell what stage of sleep people are in, by attaching little wires to their heads and seeing squiggly lines. And our sleep is actually regulated by two key processes. So the first one is sleep-wake homeostasis, which sounds really complicated, but it's actually something we all know naturally. It's when the more we feel sleepy, the more we need to sleep, basically. So it's our body's way of keeping our system regulated by ensuring that we have enough sleep to get everything done that our body needs to do, because we know that sleep is really important for a whole range of different processes that I'll talk about in a moment. But it's also regulated by the 24-hour clock. So the sun is a big influence on our body and our need to sleep. And we've actually got lots of systems and organs in our body that run on this 24-hour rhythm. And so it's really vital that we sleep at the right time to ensure that our body's doing what it's supposed to overnight. And so sleep, it's important for a whole range of things. We know that when we don't sleep properly, we don't get enough sleep, we end up with a lot of problems because we know that it's really important for our cognition and our memory in particular. It's important for our metabolic and cardiovascular health, immune function, and of course waste clearance, which is a relatively new area, but we know that sleep actually helps wash out a lot of debris from our brain overnight. And when that's not happening, we think it can have a bit of an impact on the development of brain diseases like dementia and possibly Parkinson's. So moving into sleep and ageing, so there are a lot of different things that can happen to our sleep as we age. Some of them are very natural, but it's very common to experience changes in sleep quality and sleep duration. So you can see in the graph here, babies spend most of their time asleep because that sleep is vital for development and growth. But as we get older in life, we end up decreasing both our deep sleep and our REM sleep to sort of lower levels overnight, and that's due to a whole range of different things. It could be lifestyle changes. There are some deep sleep disruptions and disorders that can come along with age, such as pain, urination, insomnia can increase as we get older, sleep apnea, where we have trouble breathing overnight, restless leg syndrome, where we have an urge to move the legs can stop people from sleeping, as well as side effects from medications. And of course, lifestyle changes such as retirement and things like that can really have an impact on our ability to sleep well in the later years. But there's one sleep disorder that our research is really focused on because it does have a really strong link with neurodegenerative disease. And that's isolated REM sleep behaviour disorder. So this is a sleep disorder where people actually act out their dreams, and it can include people talking, shouting. It can involve a lot of arm movements, sometimes punching, sometimes kicking as well with the legs. People have even been known to fall out of bed. So anything that people are dreaming about, they actually can act out. So it can result in injuries to themselves as well as their bed partner. So there are some risks involved. Now, it only happens during that REM stage of sleep. So that's rapid eye movement sleep, where we do most of our dreaming. And usually when we're in that stage of sleep, our brain sends a signal to our limbs to stay still and not move, and that's called atonia. But in this sleep disorder, there seems to be a disruption in that mechanism that actually causes people to have muscle tone and be able to act out their dreams. So we think this is part of the reason why people go on to develop other neurodegenerative diseases, because there's a very early process going on in the brain. It does tend to present more after the age of 50, but most research done in the area has focused on people over the age of 50. So we do know that it can occur earlier, but we don't know a lot about progression to other diseases in that space. But we do know that it is a very early sign of a group of brain diseases called alpha-synuclein neurodegenerative diseases. And so these are mainly Parkinson's disease, dementia with Lewy bodies, and multiple system atrophy. They're all defined by a certain brain protein that accumulates in the brain. And we know that about 80 to 90% of people who develop REM sleep behaviour disorder do go on to develop one of these diseases. So it's a really high-risk symptom, and we don't know enough about it as to why they're developing these diseases and how we can find people better in order to maybe delay or even prevent progression to other diseases. But there's a lot of challenges in finding people with IRBD. There's a big lack of awareness. You may not have ever heard of IRBD before you come here today, and that's because it's not very well known in the medical community. People who have medical education, they have a maximum of 4 hours of education on sleep in Australia and New Zealand, and very rarely do they go into these more rarer sleep disorders. So it is relatively unknown, to medical professionals and community members, which makes it really hard when people have symptoms to go to their medical professional, get diagnosed, because they may not have much awareness about it. There's also the problem with limited access to sleep specialists and services. So especially in Tasmania, we have one sleep specialist service with the Department of Health and a few private home-based services. So there's not a lot of options available for people to have testing to find if they have the sleep disorder. And it's actually really important because the only way to diagnose someone is to put them through a sleep study. So you can see this is where we wire them up with a whole bunch of wires and electrodes, because we want to measure their brain waves to see when they're in REM sleep, and also measure their muscles to see if they have that tone or not. And then we also use a camera to see if we capture any dream enactment. And this is literally what it will look like. So there's a lot involved with a sleep study, but it is the only way that we can truly diagnose IRBD. And this leads to a really big delay in diagnosis. So many people will go undiagnosed for years, nearly a decade. And it's not until other symptoms of Parkinson's or dementia emerge that people look back and think, oh, I did do strange things in my sleep, but never realise that it could have been an early symptom. So this is what we're trying to do with our research, is find easier ways to detect it, to be able to offer people opportunities for intervention, which is currently not available. So this is where our Island Sleep Study comes in. And this is a sub-project of the Island Project, which is a broader project from Wicking that's focused on lowering the risk of dementia in Tasmania. And so we invited everyone to do some of our sleep surveys back in 2022. And we're doing these biannually each year. We had an original cohort of about 3,000 people, and we asked them all about their sleep, as well as some other symptoms that are relevant to prodromal Parkinson's and dementia. So we asked about autonomic dysfunction, things like constipation, low blood pressure. We asked about some symptoms of Parkinson's, whether they think they might have any, shakiness or tremor or balance trouble. And then we also asked about pain and dreaming, just to collect as much information as we can from people who think they might have REM sleep behaviour disorder. But then we also have some objective data. So we've devised a system where we can go to people's houses and do a sleep study to diagnose whether they do in fact have IBD. So we're very lucky we're the first project that's actually done this with this specific system, and it's working really well so far. I'll go into some results in a moment. But then we're also testing people's sense of smell with scratch and sniff cards, because we know that smell loss can be an early symptom of Parkinson's as well. And then we use some activity devices, wrist-worn devices, to measure sleep-wake patterns as well, because we know that that can change in the early stage of Parkinson's too. So what have we found? Well, first of all, we looked at our survey data from 2022. And we found that about 9% of that 3,000 number cohort had probable RBD. So that's through the screening questionnaire alone. So that's people who think they act out their dreams or have been told that they act out their dreams. And so that's quite a lot, 9%, it's about 290 people we had. And then those people, they also reported that they do have some other symptoms that they're noticing. And so this is really important, because if people have RBD and they also have some very, very early symptoms of Parkinson's or dementia with Lewy bodies, then maybe we're able to detect this a lot more easily by combining what people are feeling with some objective measures as well. So what we did next is we had to find people who truly have it. So we had the screening questionnaire for people who thought they had it, but then we really needed a way to diagnose. And that's where our new Taslon protocol came into it. So this is the Tasmanian London protocol. And we were very lucky to work with some colleagues in London, where we have this 3-step method to diagnose IBD through the online screening. Then we do a telephone interview where I ask them a lot more about their sleep to really delve into what might be going on. And then people who are most likely to have IBD will go on to have a home-based sleep study to truly diagnose whether they have it or not. And through this little process, we actually found about 36 people so far in Tasmania who have IBD that wouldn't have had an opportunity to be diagnosed, most likely without their participation in this research. And so we also want to know a little bit more about dreaming, because being, REM sleep behaviour disorder, one of the key sort of features is dreaming, but there's not been a lot of research into it. And we did find some significant differences between people with and without IBD, as well as between females and males with IBD. In that females with RBD reported more nightmares related to waking life experiences. So this is another sort of screening tool that we're hoping might be able to be used. If we ask people more about their dreams, maybe we're able to diagnose or detect people a bit easier based on these symptoms that haven't really been explored much before. And then lastly, we looked into our RBD group again using some objective measures, and we did find that they had worse sense of smell. They also had some slowness in their hand motor function, which we found through TasTest, which is Jane Olty's project with keyboard tapping. And then we also found that they reported more autonomic symptoms like dizziness and constipation, and had some more falls. So putting all this information together, we're hoping we can really find a better way to detect people in the community to be able to offer intervention opportunities for them, because it's not available currently. And so this is where our future plans come into it. We're actually taking some of this work to the Parkinson's Congress in Phoenix this year, and to the Prevention Trial Forum, and hopefully get some feedback and some advice, and be able to work with some other collaborators to improve our method for the people with IBD. We have some fantastic funding from the Michael J. Fox Foundation, actually, to collect blood from people with IBD and Parkinson's to do some research into genetics, which is another understudied area that we're hoping to get involved in. We're, of course, going to look at a prevalence of IBD in Tasmania, because it's still a bit unknown about who has it because of the difficulty in detecting it. We're using our actigraphy watches to improve detection as well, some precise movement assessments, some longitudinal monitoring to better understand how long it takes people to develop other diseases or whether there's things that will delay that. And then we're also going to ask people about their thoughts on risk, because one of the things that we don't know is, do people want to know about this risk when they're diagnosed? What do they want to know? You give someone a diagnosis, there's not a whole lot we can do for them at this stage. So it's an area that needs a lot more thought when we're delivering that information to people. So lastly, we want people, if you're interested in this research at all, please get involved. If you think you act out your dreams or you know someone who does, it'd be great to sign up to the Island Project, because we're sending out our sleep surveys again in May to find more people who may have it. But then if you have Parkinson's, and even if you don't, we would love you to sign up to the Tasmanian Parkinson's Project, because we need blood from everyone to improve our understanding of genetics and Parkinson's. So even if you don't have it, we'd love you to get involved so we can take blood from everyone to improve that genetic side of things as well. And just acknowledgements. Thank you. Big thank you to Anna King and Jane Alty, my supervisors, who have helped with all of this, and all of our collaborators across the world.
Thanks so much, Sam. That's an incredible body of work, and I think you'll be very pleased once you've finished your PhD, so well done. So I think we're going to leave questions to the end, and so next I'd like to introduce Claire Meyer, who's the Chair and President of Parkinson's Tasmania.
Thanks, Michelle. It's so lovely to see so many lovely faces in here today. When I put this PowerPoint together, I didn't realise how massive my face would be. So apologies for that for people that are here at the Menzies Centre today. I am fortunate enough to be the Chair and President of Parkinson's Tasmania. I've been in this role for about 12 months now. I originally approached Parkinson's Tasmania because my dad had Parkinson's and lived with a very healthy, happy, active life, but it was a very tricky journey for us to navigate as a family, given the fragmentation of the health services and support services that are here in Tasmania. Dad was probably diagnosed 15 to 20 years ago, so there's been some significant changes, obviously, in the way that we are aware as a community and tackle Parkinson's. So when I approached Parkinson's Tasmania, I just thought I'd just have like a little role, and sometimes you've got to be careful what you wish for, because 12 or so months later, I'm in a voluntary capacity. I am the Chair and President of Parkinson's Tasmania, but it's really a privilege and an honour to be standing in this role and being able to stand in front of people today in the wider community and having a conversation about Parkinson's. So a little bit about what we do. We are a voluntary-led community organisation, and we're the leading voice for people with Parkinson's in Tasmania. We've actually been around for more than 40 years, which is quite incredible. My maternal grandmother also had Parkinson's and was one of the original members of Parkinson's Tasmania. We operate support services right across the state. As I said, we're entirely volunteer driven. We don't have staff, so everything's done in spare time between jobs and family. But we're very passionate and driven about the work that we do. And very proud that we deliver essential services that help Tasmanians with Parkinson's stay well and independent for longer. So today I'm specifically talking about Mind the Gap, and I like the little play on words, I guess, from our friends in the London Underground. I lived in London for a while, and it has a very special place in my heart. So when I was asked to speak today, I thought, oh, that's a nice little way to make the presentation interesting. So I guess where we stand as Parkinson's Tasmania, we have the privilege of working together with our community every single day, and we hear stories about what the gaps are from a practical point of view. And whilst we have amazing neurologists, clinicians, allied health professionals, there's still a lot of gaps that we're aware of. and I'll step through them quickly, but essentially we all know, or we're learning more today and over the course of our journeys, that Parkinson's is a very complex condition, and everyone's experience of Parkinson's is different. We talked earlier about both the motor and the non-motor characteristics of Parkinson's, and it's a bit of a mixed bag, I guess, for each person as how the characteristics present. The structure of our health systems don't really help us navigate our journeys with Parkinson's, either as a person living with Parkinson's, a care partner of someone with Parkinson's, or a broader support network. We know in Tasmania too, our geography, whilst it is beautiful, presents some very significant challenges for our communities, especially in regional and remote Tasmania. So it's hard to get right down into the grassroots and making sure that we reach the people that need support the most. The lack of integrated and coordinated care is also something that we're really trying to be really proactive about and tackling, and I'll speak to some of the ways in which we're doing that. But whilst we've got a very well-established Parkinson's framework within our Department of Health and THS services, there are a lot of opportunities, I guess, for those services to really be more integrated and coordinated, both in a public and a private setting. So we're working really hard to, I guess, navigate that together and find ways in which we can link up those opportunities for more coordinated care, and not just coordinated care, but consistency of care. So when you actually have your team around you, you can be sure that you're getting that consistency of care and you're not bouncing around different GPs or neurologists or allied health professionals, so people know and can work with you throughout your journey. We know especially the burden on individuals, both people living with Parkinson's and their care partners, on navigating such complex systems. And we're working really hard to make that easier for people to navigate, and there's lots of great research projects going on around that to gather data, but it's also about talking and communicating and identifying who in our community is capable, informed, and provides Parkinson's informed care and allied health services as well. We also know that stigma and social isolation is a really significant issue for people living with Parkinson's, especially at that point of diagnosis. And we're doing some really exciting work right at that preventative health, early stage, early diagnosis. When someone's newly diagnosed, we know that that's a really vulnerable period of time for lots of people, and we haven't got a great, well-established practice here in Tasmania to address that yet, but we are working on it. Also, similar to Sam's reference about in medical school, doctors only get 4 hours worth of sleep education. I didn't know that. That was an interesting fact I'll take away from today, especially given how important sleep is for all of us. I'd suggest too that there's very limited awareness among mainstream service providers about Parkinson's itself and the specific needs that people living with Parkinson's require. So we've got a few challenges, but the good news is that we're working really hard in a collaborative way across Tasmania. And you saw the beautiful photo of us all up in Canberra a few weeks ago with the launch of the National Parkinson's Action Plan, where across the university, community services, Department of Health, and other organisations and other advocates, we're really working together to make sure that we come together and have a very focused strategic way on ensuring that we are bridging the gap. We've got our lovely Tasman Bridge here lit up in blue, and for some of you that are here with us today and others online, please look out for the Tasman Bridge and other icons, including the Launceston City Hall, that will be lit up in a brilliant blue on Saturday night. And we're here for Parkinson's Awareness Month. And there's a great global movement called Spark the Night, which we've jumped on board, and we've arranged for specific icons across Tasmania to be lit up. So keep an eye out for some beautifully lit buildings in blue. It's just really an opportunity to raise awareness. So I've got 9 different examples, I guess, of the ways in which we are trying to bridge the gap. Mentioned earlier, we're working really closely with the Department of Health and the Tasmanian Health Service, both in the south and the north, to try and identify what their strategies are around neurodegenerative conditions, what they're doing in the Parkinson space, to make sure we align and don't duplicate the work that they're doing, and in fact complement and ensure that there's cross-referral and cross-pollination around education and networking. Michelle mentioned too a very important research project which is actually being jointly funded by Parkinson's Tasmania and the Royal Hobart Hospital Research Foundation, and there's significant involvement with the THS and the University of Tasmania as well. So this is for a newly diagnosed research project, essentially a pilot that will be undertaken over the next 18 months or so to develop a newly diagnosed clinic here in Hobart. This is a really big piece of work. It's really exciting. I know there's people in the audience that are involved in this work as well. And we really are very committed to making sure that we focus on preventative health, so getting in early, as I said, equipping people at that very vulnerable stage with information and referral pathways to know that they're not alone, and they can access information and support when they're ready and when they need be. This is currently a significant gap in Tasmania, but we're learning from our friends and colleagues across Australia too about what good looks like and what good practice looks like in this space. So stay tuned. We're really excited to let you know how that research project comes along. And we might be reaching out too for people to participate in that project. So one of the key things we are very aware of is that we have limited funding and limited resources, so we can only provide support groups in sort of the key areas of Tasmania. So we're looking to actually introduce a community champions model. So if you're interested, if you've got lived experience, if you're interested in being a community champion, especially in the rural and regional parts of Tasmania, please reach out to us, because this is a way that we can be sustainable going forward and really led at a community grassroots level. I'll talk in a minute about the partnership with the Tasmanian Lifeline. We've got a partnership with them as well as a number of other community organisations where there's lots of alignment. So Palliative Care Tasmania, how to deal with grief, especially anticipatory grief, is a big part of our puzzle at the moment. And also working with MS Plus, because they actually have a lot of people that come to them that have Parkinson's already. And we're looking at ways that we can partner with them and share resources in the future. In exciting news, we've got a new community operations officer, and I'll speak about that in a moment. We work obviously very closely with Wicking and Menzies on a number of projects, including Parkinson's Net and the Tasmanian Parkinson's Project. We advocate really strongly every day at state and federal level. This is a new skill set for me and a number of my friends and colleagues at Parkinson's Tasmania, but we know that having a loud voice and a constant voice makes all the difference, especially leading up to state funding. And we know that it's going to be a really tricky budget that will be delivered in the next month or so. And whilst we're hoping that we get seed funding for the first time ever, we can't rest on our laurels, I guess, and we have to keep on advocating every day. And we are one of the founding members of the National Parkinson's Alliance. I'm lucky enough to be a director on that board as well, and it was a privilege to attend the launch of that in Canberra recently. One of the key things that I wanted to speak about today was a partnership that we've got with the Tasmanian Lifeline. This is a really innovative research project. I'm going to try and use the tech, so you might have to wait momentarily just to make sure I do this properly. Let's see how I go. Okay, hopefully this doesn't blare everyone out of the seats.
And Lifeline joining forces to lend a compassionate ear.
Our service, a Tasmanian Lifeline, is connected and ready and resilient and able to work very closely with Parkinson's Tasmania to meet the needs of the Parkinson's community.
We are about to start training together, providing specialist training to a Tasmanian Lifeline staff specifically about Parkinson's and what that looks like for our Parkinson's community.
Tasmanians living with the disease will be encouraged to access the telephone service.
There's a lot of stigma that comes with a diagnosis of Parkinson's, so people might not actually feel comfortable talking to their family and friends straight away.
We are seeing increasing numbers of people, increasing younger people, more men, which is really pleasing. We're seeing reach out to a Tasmanian Lifeline.
The partnership comes in the shadow of Meyers' budget.
I think the more that services and community groups can work together, the far greater reach we can have with the same amount of funding.
Their voice should not be lost in some academic argument around debt and net debt and operating balances.
Liz Brown making the case that investment in prevention makes economic sense.
So we are preventing people from escalating and needing more acute levels of care.
So that they're not as big a burden on the health system as they possibly could be, but more importantly, they're getting the help they desperately need.
You can contact a Tasmanian Lifeline between 8 a.m. and 8 p.m. 7 days a week. Alex Johnston, Win News.
I might need your help getting back to the slides. So this was a really massive piece of advocacy work that we undertook, and this is a bit of a new strategy for us at Parkinson's Tasmania. We've worked behind the scenes for so many years, but we know we really need to get out there. And I guess the key message from that is that a Tasmanian Lifeline is actually a service that is run by Lifeline Tasmania. It's available every day of the week, and we're undertaking training with the trained counsellors and psychologists that man that line to make sure that people with Parkinson's have someone to talk to, as well as their care partners, 7 days a week. We obviously have a phone line and information line ourselves, but we don't have the resourcing to make sure that there's someone at the end of that line every time. The beautiful thing about a Tasmanian Lifeline too is it's run out of Tasmania for Tasmanians. So they know what the challenges look like. They know the challenges about getting to appointments and the frustration that comes with that. They're also very aware of the communication challenges that people with Parkinson's may have. And I think that's a really important piece of education for the counsellors to have. So there's the number for a Tasmanian Lifeline, and I encourage you to pick up the phone for a chat. The other excellent thing about the service is that they have a return call service. So you might be talking to Ben on the phone, and Ben will ask you, hey, would you like me to call back and check in and see how you're going in a week or so? So I think especially targeting the social isolation and the stigma that we know that people with Parkinson's and their care partners often endure. I think this is an amazing opportunity for people to know that there's support at the end of the phone 7 days a week. So that rounds out my presentation today. I hope it's been interesting and provides a bit more about the social context, the community context that we're working within with Parkinson's Tasmania. We do have a website. You can click the QR code there. It will take you straight there. I did mention too, another important part, a bit of news for us is that we've got a new community operations officer that's recently joined us. Jackie Christie's her name. You may have come across Jackie. She was a Parkinson's nurse here in Tasmania for many years. She also works up in palliative care. She's got a deep knowledge of Parkinson's, and whilst we can't give clinical advice over the phone, Jackie has a deep knowledge of what this looks like for people living with Parkinson's and their care partners, so can help navigate, refer you across to some of our Parkinson's nurses across Tasmania. As I said, Tasmanian Lifeline's there, and we've also got our Parkinson's Tasmania information line where you can call at Jackie. She might not be able to answer straight away, but at least you know that someone will give you a call back and you can have a chat. Thanks very much.
Thanks so much, Claire. Claire has a full-time other job other than this, and I mean the work that you've done over the last year is just unbelievable, and really want to thank you for that. Okay, last we've got Celeste, who is a PhD student here at Meyers, and she's going to talk about Parkinson's and employment. She's at the start of her PhD, so it's more about what she's going to do. We hope.
Hi everybody, so I'm Celeste. I am a physiotherapist who did my Masters in Health Economics, so this is my way of merging the two in my PhD project on Parkinson's and employment. So Parkinson's is generally associated with older males. If you Google Parkinson's, these kind of pictures come up. This is from a medical textbook, very focused on the physical motor symptoms. And while that's important, and the older population is, or the increase in the older population is a big reason for the increased prevalence in Parkinson's, Parkinson's also looks like younger people who are at work. And early onset Parkinson's affects people, or people get symptoms under the age of 50. About 15% of Parkinson's cases are early onset Parkinson's, which culminates to about 1 million people worldwide. This has also resulted in a lowering of the average onset of Parkinson's, and considering that the retirement age or the pension in Australia is 67, it means a lot more people are being diagnosed in their working years. So people with Parkinson's, a systematic review has found that they tend to leave work around 7 years earlier than their peers, and generally 3 to 5 years after being diagnosed with Parkinson's. They also report much higher levels of absenteeism, which is when you miss work due to your symptoms, or presenteeism, where you're at work but you have difficulty with your work tasks. And this leads to high productivity losses, most costing studies showing that the indirect costs far outweigh the direct costs of treating people with Parkinson's. But Parkinson's doesn't only affect society and the economy, it has a profound impact on the person. Work is so closely linked to our sense of purpose, our sense of identity, and our roles that we have at home and in the community. Conversely, research has shown that people with Parkinson's who stay in work have better quality of life and better health outcomes, which is also a good reason to keep people with Parkinson's at work. So why do people with Parkinson's leave work early? This diagram shows a myriad of well-researched and hypothetical reasons that people may leave work early. And there's a key focus on the person, which could be Parkinson's symptoms specifically. A lot of people with Parkinson's report that the non-motor symptoms, so things like brain fog, fatigue, mood disturbances, those are actually much more burdensome at work than the physical things like the tremor and things like that. Then we get to occupation and job type. This sort of focuses on what your job needs from you. Is it a high level of cognitive load, physical ability, manual dexterity, all things that people with Parkinson's may suffer with. And last, the environment. This is looking at things like, yes, inclusive environment, doors that open automatically, but more importantly, it's the work culture and the values at the workplace, which leads me to my next slide on disclosure. So thinking about disclosing your condition or the condition, legally you don't have to, unless it's a health and safety risk or you're unable to do your main work tasks. And in a healthy, supportive work environment, this can lead to reduced stress because you don't have to hide your symptoms. Everyone can be open about it. And it may also lead to helpful workplace accommodations that might allow you to work for longer. This is just an example of someone in the European Parkinson's network who reports being open about her diagnosis because she wants to sort of be a leader in workplace inclusion. But in reality, most people don't want to disclose. They fear stigma, they fear losing their job, they fear losing potential job opportunities. Here's another example of a doctor in the UK who was diagnosed with Parkinson's at 28. And even though she was running her own medical practice, she went to extreme lengths to hide her symptoms, saying that she would sit on her hand if it started to tremor, or she'd stand up when she felt a tremor in her leg coming on. So I just thought it'd be good to know what is a reasonable accommodation. and what people with Parkinson's have the right to request at work. And these are various, and these are just a few examples. Things like flexible work hours and work from home, which allow management of those fluctuating energy levels. Then adjusted duties, or getting someone to assist with certain duties, an accessible work environment or work culture, ergonomic adjustments like an adaptive keyboard, assistive technology, if you're having trouble writing or typing, things like speech to text is really helpful. But many people don't know these exist and that they're able to ask for these things, and not just people with Parkinson's, but their employers too. So occupational therapists are leaders in workplace accommodations. They do work visits and can be very helpful in giving recommendations while also looking at how to improve your cognition, your memory, and fine motor function. Other allied health that can help support people with Parkinson's stay in work. This is not a comprehensive list. There are tons, but physio can keep you mobile for longer, help you maintain your balance, and psychology is crucial for people with mood disturbances as a result of Parkinson's, which are really common. Here, early intervention is crucial, and this is not just us saying that. This is people with Parkinson's that have had to leave work early. They've reported that, they wish they started with allied health earlier, and that's also one of our aims. So the limitations of current research, it's applicable to me since I'm starting off and finding my way. And I just want to say if you look at the experiences of people with Parkinson's at work, even though there's a lot of literature on people with Parkinson's, it's generally an older population, and very few look at those that are still actively involved at work. And none in Australia at all, or Australasia. So all the things I've presented to you today all come from the US, the UK, and Europe. And none really focus on, okay, we say these supports and accommodations are available. How effective are they? How do people with Parkinson's feel? Do they actually help? Where are they accessible? So we need to look at all of those things. One example is the National Disability Insurance Scheme in Australia, which helps or aims to help people achieve employment goals, but we aren't sure if they do, if they don't. So we need to look into that. And also ask people with Parkinson's, besides what is already available, what would you like to have as a support at work? So this leads me on to my project. The overall aim is to support people with Parkinson's to continue working, to understand the experiences of Parkinson's at work, mainly in Australia, throughout Australia, and globally. Look at the perspectives of the current supports available and how accessible, feasible they are. To look at those person, occupation, and environmental factors and how they all interlink to either keep someone working or get them to leave work early. And lastly, we hope to co-design and pilot a feasibility study for a program for people with Parkinson's who are working or would like to re-enter the workforce. So again, my project sits under the Tasmanian Parkinson's Project, and we need more people with Parkinson's and without, especially in Tasmania. Even though, it's called the Tasmanian Parkinson's Project, we have quite a low Tasmanian participants. So if you'd like to join, please scan the QR code. That's all from me. Thanks.
So I'd just like to thank all the presenters. We've got time now for some questions. Can people ask questions online? I'll read them. Okay, you'll read them out. So first we usually have students asking questions.
That was a lovely talk. My question is from Sam. So you mentioned in one of your studies, there's a home-based screening tool for IRBD. So I was wondering about its feasibility in terms of implementation in clinical practice.
Yeah. So there's actually quite a few different screening questionnaires available for IRBD. They kind of vary in their sensitivity and specificity. because they're really good at identifying people who might have it. But the problem with IBD is that there are a range of other sleep disorders that can have similar symptoms. So even though the screening questionnaire can pick up some people, we don't know if they definitely have it or if they might have a different sleep disorder that looks like it, which is why the sleep study is necessary. But there's a single question that's often used in clinical practice, which just asks, do you think or have you been told that you act out your dreams? And that's used most commonly because that's the key symptom. So it's useful for helping find people, but we can't rely on it to definitively diagnose people with IBD.
Are there any questions online? Well, I'm really curious about the sex differences. Can you tell us a little bit more about that?
Yes, so I guess because Parkinson's is more prevalent in males, there's this, overarching theme that IBD is more prevalent in males as well. But what we found in all of the past research is they've come from sort of clinical or research centres which have a high, patient base of males, because we think what's happening is males actually present with bigger dream enactment compared to females, so they're not as easy to identify. And that's one of the reasons why we did the research into dreaming, because we did find that women seem to have different dreams to men in IBD. And if we can use that as a way to detect females, we might be able to find them more than is currently possible, because we think that it's likely they have, smaller movements or not as injurious as males do. So it's a very under-researched area, is how females with IBD present compared to males, because most of the research has been in males.
Thanks everyone for a great talk. I've got a question for you as well while you're there. I was just interested in your use of wrist-worn watches, and obviously you're using research quality devices, but many of us, have Fitbits and things, and I just wondered if you could comment on, how useful they are in terms of accuracy and whether they, could give the general community any clues.
Yeah, so things like Garmin, Fitbits, Apple Watches, you get your sleep data from them. They're good at giving you an overview of your sleep, but when it comes down to looking at the percentage of sleep stages, they tend to be quite inaccurate, because they use algorithms based on movement and heart rate, and they're trying to identify what sleep stage you're in, but they're really bad at doing that. So they'll tell you, they're good at saying, yes, you slept for this long. That's pretty accurate, because you're not moving when you're asleep. But what we're using, we have some watches that do similar things. They're called actigraphy, and they look at sleep wake patterns over a 24-hour period, over many, many days. And what we think is that people with IBD will have different patterns in their 24-hour cycle, in terms of they will have more movement overnight, obviously with the dream enactment, but then sometimes more naps during the day as well. But in general, they're not very regular wrist-worn devices, aren't very helpful in that respect. But I will say, if you have a watch that has oxygen saturation monitoring overnight, really good at picking up potential sleep apnea where you're not breathing. So they can be quite handy for some things, but in terms of sleep staging, not so good.
Disappointed about that. Question online?
Yeah, two online actually. So Karen's asked, who is the best support service to contact for social support for elders with Parkinson's? Would that be Pipeline or Parkinson's Support Direct?
So I think the question was, who are the best support services to contact for Parkinson's specifically?
Yeah, elders with Parkinson's.
Elders with Parkinson's. Well, I'm hoping that it's us at Parkinson's Tasmania, so thank you for the question. We've got a lot of referral pathways as well, so we're a one-stop shop, I guess. So pick up the phone to us if you want an overall assistance and guidance as to what support, especially for ageing elderly people. A Lifeline Tasmania is more of a psychological support methods, counselling support service. If they're informed about Parkinson's specifically, they may not have And we're in our early stage of training with Tasmanian Lifeline, so they can give that high level support service in terms of mental health. But yeah, please give us a call at Parkinson's Tasmania, or drop us an email and reach out to Jackie.
Well, there was one more question online from Narrett in Victoria, who has identified themselves as a PSP atypical Parkinson's person. Is asking how important is REM sleep?
That's a good question. It's pretty important. I mean, all the sleep stages are important because they all have a different function. So we know that stage 2 sleep is really good for memory consolidation. REM sleep is also involved in learning and memory. So it's all of the sleep stages are just as important as each other, because we know that if you don't have one stage, then you will notice, a difference in how you feel during the day, whether that's, your wakefulness or your being able to think clearly, your grogginess. So every sleep stage is really important for some function to keep us, functioning well during the day.
I was wondering, I don't know if anyone can answer this one, how common it is for Parkinson's to go undiagnosed. Like if they have mild symptoms that, might look like a result of aging, like a loss of balance, or even psychological problems that are also common in the general public and things. So is there an estimate of how many people go undiagnosed?
It's a fantastic question, and we're grappling with this very thing right at the moment. The data we rely on to inform the prevalence of Parkinson's itself is based on pharmaceutical benefit scheme data, and there's some wonderful projects, one that's being led out of Tasmania, I think, too, with Associate Professor Barb de Graaf, about data, because we know that we may actually be underdiagnosing in terms of, and so we don't have a true understanding of how many people actually have Parkinson's, both in Tasmania and across Australia. So, but it is very hard to diagnose Parkinson's, and I guess that's why we're working so hard. We need to make sure that we can identify and diagnose Parkinson's earlier and in more of a, what's the word, Michelle? I'm not clinical, so
you're right though, because things like constipation, depression, anxiety are all very common, and it's not until someone actually starts to present with some of those motor signs, and it's that constellation, slowness, and then a stiffness or a tremor that diagnosis is made. But I guess to say also that some of the work that Professor Jane Alty is doing with some of her tests, if they were kind of done earlier, they are, I guess, more objective as well. I mean, a clinical diagnosis is made by feel and sight. There's no, I guess, lab test at the moment for Parkinson's. So many people are diagnosed, well after the time that they first present to a doctor with problems, many, many years after.
Time for one more question, I reckon.
I've got one. A quick one. Can someone from Interstate be involved with the
Absolutely, yes. Anyone in Australia.
From Claire Caldwell, as shift work is so disruptive to sleep hygiene, is it something that a person who has a parent with Parkinson's should be aware of or concerned about?
That's a really good question. I mean, it's hard to, I don't think there's been a lot of research into, sleep as or poor sleep as a sort of a risk factor for Parkinson's. So we don't really know. I think shift work in general we know is pretty bad for sleep. It's actually now classified by the World Health Organization as a carcinogen, because people who do shift work have a higher risk of cancer, and we think probably also other comorbidities as well. So if you can get out of shift work, that's ideal. But if not, shift work is one of those things that you have to work around and try and sleep when you can to try and get as much sleep as you can. But it's not easy being a shift worker. So I think, you just try and optimise your schedule as much as possible to keep your brain healthy, because we know that sleep is really important for brain and body health in the long term.
Thank you so much, everybody, for coming. A big thank you to Sam, Claire and Celeste for your presentations today.